Oh, my back. Oh, I think you slipped my disc back in. That's how that works, right?
No,
Huh.
stay tuned. We'll tell you why at the 50 Shades of Pain show. Hi, welcome to the 50 Shades of Pain show, where we empower our community by demystifying pain, both physical and emotional, and giving you the tools that you need for optimal health. I'm Dr. Donish, the medical director of Wellward Medical here in Lexington, Kentucky. I'm here with my co-host, Dr. James Escaloni.
Hey, everybody.
And today we're talking about a great topic.
Slipped discs.
Right. How often have you heard a patient come in and say, well, I slipped my disc and blah, blah, blah. And then it's like there's a dozen different variations of what happened after that.
Usually once, twice a day.
Yeah, it's a pretty common misconception that you can actually slip a disc. And what people often mean is that they've injured their disc, or at least that's radiologically what's showing up on an MRI. But we often find people to have that misconception of what a slipped disc should feel like, and they label it as such because that's what's common lay term for it.
Yeah.
But it's actually extraordinarily difficult to quote unquote slip a disc. It's not one of the most common reasons people hurt.
So I still remember years and years ago that the disc is almost like a donut and a jelly donut.
Yeah.
And when you think about that, it's like, okay, that could be a good analogy, except think about if you go like this to a jelly donut, squirts all over the place. Well, that would mean anytime that one of my kids jumps on my back, I'm done.
Yeah.
You know, my discs are squirting out all over the place.
No,
Problems.
discs are way more resilient. I think of it more like a tire, like a plastic tire, where you've got this thick ring of plastic around it, but then as you get to the inside, it becomes really squishy, and actually it is jelly on the inside. That's why people think of it as a jelly donut. So you could think of it as a jelly donut sitting inside of a big tire tube.
Oh, that's kind of a weird dietary thing. But all right, another episode. Yeah, but for when I remember my gross anatomy classes, when we're actually hacking away at the spine, just try to get to the stuff that our instructor says get down there, we'd get to that outside tire stuff, the annulus, and it was just the scalpel was getting dull over and over again.
It's a pretty dense, thick tissue. The way that I think of the disc is you've got a jelly center that is live cells. That's where the living part, kind of like your nail bed, the rest of your nail is just dead tissue that is forming a protective boundary. And the disc itself is the same thing. The center of the disc, what we call the nucleus pulposa, that's alive, and that has replicating cells that keep growing over time.
Oh.
But as those cells grow and put out substance, that substance they put out is dead tissue. It's not a living entity. It's just a ring that, like the rings of a tree, just forms out and creates this boundary around what we label as the disc.
That's really interesting. I like that. So with the injections that you do, you often have to go around that disc and sometimes into the disc. Is it still, after somebody's been injured, is it still very taut back there?
It is. It's still a pretty resilient piece of tissue. Often, though, what's given away or what's gone with the damaged disc is the ligament that surrounds the disc, or that there's been so much loss of stability at that segment that there is a little bit of shifting back and forth. And what's really happening in that situation is the bone that surrounds the disc is the only way the disc gets fed. So there are tiny blood vessels that surround the disc, but nothing that goes really inside the disc. It's the squishy part of the disc is actually on the squishy part of the bone. Like if you were to take a spine, the ring around the spine bone is hard and bone and calcium, but the center part of the spine is actually quite squishy, and sometimes we even see fractures where the disc is squished into that bony end plate. Well, that bony end plate's role is to feed the disc. And if you have a loss of stability around the disc, so if you imagine the whole segment of the spine, there's a disc and then there's bone surrounding that disc. Well, that bone is held in place by ligaments, and if those ligaments fail, then this starts to shift back and forth. And discs are really good at compressive forces, but they're really bad at shear forces. So it's that shearing that causes miniature fractures within the bony end plate, and that reduces the nutrition to the disc. So over time, the disc starts to dehydrate and get weaker and weaker and weaker, to the point where somebody might be in a bent over position, and then somebody comes and slaps them on the back
And slips their disc back into place.
and that does not happen, James. No, but you can injure yourself if you've got weak structures around that and your muscles are not holding the strength that they should be to compensate for the weakening ligaments.
All right. So I can see how people could think that they had slipped a disc out, because if they're bending forward, which is usually how people injure their back, something like that, and they feel this intense pain in their back, I would think it was a disc if I didn't know any better. So if the disc isn't really slipping out when they're bending forward like that and feeling their pain, what are some things that you've seen that are generally more likely to be the culprit?
So oftentimes it's a correlation, meaning that two things appear at the same time. And the thing that's more visibly apparent is the disc. What's not visibly apparent in that kind of an injury are the ligaments and the soft tissue around the structure, the spine. And those, you have to have an MRI that cuts it smack dab right in the middle of that ligament. Otherwise, it's invisible. You can't see it. And so that's why people focus more on the disc, because the disc is readily visible. But more often than not, the injury in that case is that the ligaments aren't holding their stability, or they're not holding well enough. And somebody comes and has a big impulse or a big shock to the system, and that ligament that was just barely holding on now has like a small sprain in it. And that causes a huge nerve reaction, because your body isn't going to let instability exist in the spine. It tries to fortify everything, so it cramps down all of those muscles really, really tight. And what most people feel in that moment when they think of this as a slipped disc is a muscle spasm that's so intense they can't move. The typical course with that is about a week, 4 or 5 days, something in that ballpark, where people feel intense pain, very, very uncomfortable to move in any kind of plane of movement. But then after about a week, it settles down into this dull, lingering ache, which can last for 5, 6 weeks or so, and then it starts to settle and go away. The damage is that coincident with that injury, you may see like a disc herniation or a disc bulge. And people get really panicky about that, because for years and years and years, that meant surgery. What we're finding, though, is that very few of those cases actually need surgery. In fact, in many of those situations, the surgery is just a Band-Aid that creates other problems that will show up a couple years down the road.
That's why I often see that discectomies have a tendency to lead to further and further surgeries.
Exactly. I've seen so many patients years and years after a discectomy, and their disc has essentially eroded all to nothing, because if you go back to remembering what the disc looks like, it's
Nice
that
tire.
It's that tire. And what happens if I poke a hole in that tire? It's just going to keep deflating to the point where it's just no longer a functional tire. And that's exactly what happens with discs. Is the moment you start to mess with it and cut into it, you're introducing scars that can then lead to other problems down the road.
And that's probably a big reason why we've developed the pain mapping process before we do something like PRP or BMAC for these patients.
Or even suggest that somebody really is in a position where surgery is unavoidable. There are very few instances where surgery is unavoidable, but in those situations, I mean, it has to be done. The mainstay of what we do when we're seeing that kind of situation is we want to first identify what's the main deficit in this situation. The disc might show up on the MRI, but is that really the main problem, or is it the ligaments and the muscles and all those other connective tissue around that structure that's problematic? So we go through that pain mapping process to better localize it and determine, is this something that can be repaired with exercise, with regenerative therapies, or does this have to go to a surgeon's office?
And so one of the things that I've appreciated so much, and we've talked about it on other episodes, are we'll look at the person's MRI, we'll obviously see a bulging disc, but then when we go in and actually test out the disc,
Yeah.
Doesn't hurt.
Oftentimes those findings are essentially scars from the past. Like at some point in that person's past, they had an injury to this disc, which is now healed, but it's left a scar. And that's not the problem. It's the other structures that led to that injury happening that are the problem.
And just to clarify for them, you're actually going into somebody who's awake with a little bit of numbing on their skin and tapping around those areas on their back just to make sure that, are you sure this doesn't hurt after
Right.
looking at the MRI?
Yeah, and I mean, there's a lot of examination and history before that to get the picture of what we think is wrong. But correct, like when we're doing a pain mapping procedure, we're in essence numbing very discrete parts of the spine. So like, for instance, if this is, I'm going to pretend this is a spine, this not, but let's pretend my hand is a spine. If I see problems in these 3 fingers, but I don't know which one is an active problem and which one's a scar from the past. So the only way that I can figure that out, if examination isn't clear enough, is to just go discreetly to each finger, numb it, and see what changes. The only other way to do that is if I can examine it. And the reality is, when we're talking about the spine, there's so much tissue that you have to go through that it's impossible to really discriminate between this finger and this finger. And that's why the pain mapping process can be so helpful.
Oh yeah, it's helped a lot of people to avoid surgeries.
Absolutely.
And helped a whole lot of people who've had chronic pain that they didn't know where it was coming from. We figured it out.
That's right. And it really is our first main step in getting people well, because otherwise we could just be squirting regenerative products or injection medications throughout the body and really making no progress until we completely understand the mechanism of what's wrong.
We don't like to guess with your body.
That's right.
All right.
Well, if you enjoyed this, please feel free to comment and give us feedback of what information we lacked or we missed in this. We always like to read those comments because it really helps us form our future shows. And if you found this interesting, you're welcome to look up other videos that we've done on YouTube or visit us on our website at wellwordmed.com. We've started a podcast, so there's a lot of different avenues that you can reach us and get more information about your body. We want to help educate you.
So until next time, I'm Dr. Escaloni.
And I'm Dr. Danish. We'll see you soon. Finger guns?
Yeah.
Again?
I always like the finger guns. Maybe